Boom. Ooh. All right, so folks are slowly joining us. I do love this noontime appointment. This is great. Feels like just more of a casual conversation than a full-on half-day webinar. Oh, and I'll
Yes.
never forget Dr. Angel. Remember when you moderated our first one?
Oh,
And
yes.
we pre-recorded everything. It was just so wild, but here we are today. It's great. Ah, all right. Well, as everybody gets started in here, I just want to say welcome from the Breast Cancer Coalition. We're officially into September. I don't know if you believe it, but I did take my girls to school today, so it's official. And as you may know, September is Gynecologic Cancer Awareness Month. We at the Coalition like to say awareness has never been enough. And we are here for education and support for those with gynecologic cancers. And I wanted to just thank both Rachel Rosen-Simpson, our program manager, as well as Cynthia Angel, who is joining us to share some of her expertise as well. And as people are joining us here, I just want to talk about today and kind of how things are going to work. We've got a 1-hour presentation from Dr. Angel on updates in medical treatment for gynecologic cancers. Next Wednesday at noon, we will hear from Dr. Nicole Rubin, and she will be talking about long-term effects of radiation and chemotherapy. On the third Wednesday of the month, we will hear about sexuality during and after cancer treatment. And that'll be with Christina Galton, Jocelyn Bouchard, and Carly Katulov, all from URMC. And then join us all back here Wednesday, September 25th at 7 p.m. on Zoom. We'll have all of our panelists back, as well as 2 survivor speakers. It'll be a Q&A and a recap, and we'll hear about our survivor speaker stories. And we really hope that everybody is engaged in this different format this year. All of the recorded links will be on our website, and join us. I'm going to turn it over now to Rachel Rosen-Simpson. Welcome.
Hi, everyone. Thank you all for tuning in with us on your lunch hour. We're really grateful to have you, and I am really grateful to be here with you. I just started my role with the Breast Cancer Coalition as the program manager on August 1st. So I've had a few weeks to hit the ground running, get my feet under me, and ta-da, here we are. But enough about me. Dr. Cynthia Angel is joining us today to give a presentation about advances in medical treatment. And honestly, when I was asked to put together or help put together this webinar series, there's no one better to kick us off and to talk about updates than Dr. Angel, because she has been a gynecologic oncologist for over 35 years. She is a general badass. I don't know if I could say that, but I just did. She and I have been working together to serve the gynecologic cancers community for 12 years. I think this is lucky number 13. And it has been a joy to get to know her and her family over that course of time. But she is full of sage advice, and I think her presentation will be illuminating because there is so much new information, new treatments, new conjugates, and yeah, take it away, Dr. Angel.
Hi. As Rachel said, my name is Cindy Angel. I've been a gynecologic oncologist for a long time. I'm happy to say that the latter part of my career, there's been many more advances than the initial part of my career. And it seems like new things are happening every year. And I was delighted that she asked me to do this, because this is really the first year that standards of care have really changed. I mean, it's not, I did this talk a few years ago, and yes, there were new things in the offing. We were excited about some preliminary evaluation, but this is the first year where standards have really changed. So with that, I guess I'll share my screen and we'll start. We're going to talk about the medical management of gynecologic cancers. We're not going to talk very much about surgery at all, although I might make a fleeting mention about it, but we won't really be talking about that. So when you talk about gynecologic cancers, the cancers that I'm going to talk about today are ovarian cancer, fallopian tube cancer, and primary peritoneal cancer. And I group them all together because they're thought of as being almost the same entity. They are staged the same and they're treated the same. There might be some slight differences, but in general, they're treated the same. Then there's uterine cancer, which the two big kinds of cancer that we have are endometrial cancers, which start in the lining of the uterus, and a uterine sarcoma, which can start in the muscle or the soft tissue of the uterus. And the last one we're going to talk about today is cervical cancer. Just to remind everybody, if this is the vagina, this is the cervix. That's where the cervical cancers start. The endometrial cancers start in this lining of the uterus, and the ovary and the fallopian tube cancers usually originate in those organs as well. There is, as time goes on, we believe that ovarian cancer for all these years has been misrepresented and is probably a fallopian tube cancer, but we haven't, a fallopian tube cancer that has spread, but we haven't made that jump yet. So in general, treatments for these kinds of cancers include surgery, where you remove the tumor, radiation therapy, where you treat the tumor with radiation beams to shrink it and kill it, and chemotherapy. Those have been the usual treatments that we've done for decades. More recently, we're going to talk about targeted therapies, and where specifics, enzymes or specific cell functions are targeted. Immunotherapy, which is very popular right now, where we have our immune system destroy the cancer cells, or hormonal therapy, such as the progestins or the aromatase inhibitors that for a long time we've been using those in breast cancer, but they're also very useful in gynecologic cancers. The other thing that has changed a lot in my career is that we give chemotherapy, or we give therapy at different times. In the beginning, we would always do surgery and then do chemotherapy afterwards. Now we do chemotherapy at the beginning to shrink the tumor and then give surgery or radiation therapy. The other big thing is maintenance therapy. It used to be you had your surgery for these gynecologic malignancies, had your treatment, and then you were done. But now we're doing maintenance chemotherapy or maintenance targeted therapy, and we'll talk about that. So this is a picture of what ovarian cancer, fallopian tube cancer looks like. It's these cells that are on these fibrous stalks, and just looking at that picture, you can't really tell where it came from. Most of the cancers are what's called serous cancers. That's how these particular cancer cells are categorized. And as I said, in advanced cases, they're difficult to identify the primary, but they're all treated in the same fashion. With this group of cancers, the initial presentation is often with an advanced disease. Remember, this cancer was originally diagnosed or thought of as a silent cancer or a silent killer. But as we've known, these cancers aren't silent, but they seem to whisper, in that patients always have these or present with symptoms that we always think of in passing as being minor: bloating or abdominal distension. Some patients in more advanced cases will get some fluid around the lung, which is a pleural effusion. Sometimes their bowels obstruct. You'll talk about ascites, which is fluid in the abdomen. an omental cake or nodules on the diaphragm. This is just a CAT scan. Think of a CAT scan as being a loaf of Italian bread that's sliced, and we're looking at one slice. It sounds a little odd, but if you think of it that way, and in this slice, you could see this is an omental cake. This little bit over here is ascites, and on this other side, this is ascites as well. This is just another picture of ascites and an omental cake. I don't want to keep this up too long, but this is actually a picture of ovarian cancer in that it's often little tiny tumors. I used to talk to patients about having freckles that can coalesce, and that's how these kinds of cancers spread. In the beginning, in 1934, a gynecologic surgeon talked about removing the cancer, and it was Dr. Tom Griffiths who published a paper in the late 70s talking about primary debulking. And then from 1975 until about 5 years ago or so, maybe 10, but for decades, this is how we did surgery, and we would remove as much of the cancer as possible. Some of the patients would have colostomies, they'd be in the intensive care unit. And we also characterized patients into having optimal or suboptimal cytoreductions, and optimal would be no tumor nodule greater than 1 centimeter behind. One of those freckles could measure a centimeter or 9 millimeters. And if that's what you left behind because it was on a vital organ, that would be characterized as optimal cytoreduction. Now our goal has even changed further, and the goal is to remove as much cancer so that there's no gross residual behind. Because we're doing neoadjuvant chemotherapy before the surgery now, that is much more of an achievable goal. As I said, primary cytoreduction was a heroic procedure where in 2016, so it was within the past 10 years, was the first paper that really recommended that we give chemotherapy first. So in neoadjuvant chemotherapy, we give 3 to 4 cycles of treatment, followed by an interval cytoreduction. And then after surgery, we would usually give an additional 2 to 3 cycles of chemotherapy. This has been such progress for our patients. They're much less extensive procedures. There's fewer complications, less ICU stays, and the outcomes are similar, whether you do this big operation that's very difficult on the patient first and then give the chemo, or if you give the chemotherapy first and then do surgery. We, in this city, perform these operations using robot-assisted laparoscopy, and a lot of the patients go home the next day. I had done a similar talk a while ago, and this is back when we first started treating ovarian cancer in the 60s. And cisplatin was introduced in 1978. That was one of the most effective agents that we've ever had for ovarian cancer. And it was in 1992 that Taxol came along. So as you can see, there were a couple of other drugs that came along, but none of them were as good as cisplatin or carboplatin now and Taxol. And some of the newer things were introduced up to the 2020s. And you'll see even beyond that, there are newer drugs. What's really amazing to me is if you look in the 1960s and 70s, there was nothing or very little that was available for these cancers. And now there's a multitude of drugs and different ways, different approaches to attack the tumors. So the one thing you have to realize is all treatment infusions are not the same. Some people just lump them all into, I'm getting my chemotherapy, but chemotherapy is different than targeted therapy, which is different than immunotherapy. Before I talk about the therapies, I need to tell you that if a patient has ovarian cancer, fallopian tube cancer, or primary peritoneal cancer, they should have genetic testing. That's germline testing, which means all of your cells have the same genetic makeup. And that can be done. We used to do it by blood, but now you can do it with saliva. And that we do panel testing. So you can test for the BRCA1 gene, the BRCA2 gene, and a variety of other genes that can make a difference in the treatment, not just of ovarian fallopian tube cancer, but also endometrial cancer. The important thing about the germline testing is if you have the gene, then 50% of your children could have the gene. They have a 50% chance of having it. So that germline testing is handed down during generations. Now, if you are negative for germline testing, then your actual tumor should be tested. And what happens is they take a piece of your tumor and send it off for testing to see if it's BRCA1 or BRCA2. Interestingly, you could not have a germline testing mutation, but your tumor can have a mutation. And if your tumor has the mutation and you don't, you won't pass it on to your children, but different kinds of agents can be used against those tumors. And then the other thing we look at is what's called homologous repair deficiency, which is different than BRCA1 and BRCA2. And what that means is if your cancer has if it has a defect in it, then it can't repair. It's innately unable to repair a genetic defect, and there are certain things that can be used against those tumors as well. Now, why is it important that you have the genetic testing or your tumor has testing? And that's because half of the cancers, the ovarian, primary peritoneal, and fallopian tube cancers, about half of them have genetic mutations in these homologous repair genes. And that means that you can use certain kinds of treatment, such as PARP inhibitors. In addition to not having the ability to repair genetic defects within the tumor can have what's called microsatellite instability. And it's important that you test the tumor for that as well, because if your tumor does have this deficiency or a deficiency in mismatch repair, then immune therapy would be an option for you as well. So now that I've told you what, if you are diagnosed with this cancer, you yourself should have germline testing. If that's negative, your tumor should have genetic testing, and that will help with the treatment. Chemotherapy, which is platinum and Taxol, as well as some of these other agents, affects the cancer cells during cell division. So this is the cancer cell cycle. A lot of the cancer cells are in this G0, which is where they're just at rest. But if they go through the cell cycle, it's at different places where these chemotherapies interrupt the cell cycle so that when they go to divide, they can't, and then they die. And that's how chemotherapy works. We often think of it as killing the cancers. It doesn't really kill it per se. When the cancer cells go to divide, the division is interrupted. And then what happens is when the cells go to divide, they can't, and then they die at that point. Now, targeted therapy, a lot of you have heard about this kind of targeted therapy, and that's Avastin or bevacizumab. So what it is, and obviously it's very complex, but if this gray lump of cells over here is the tumor sends out messages, chemical messages to the surrounding blood vessels that then in turn causes the blood vessels to grow and feed the tumor so that the tumor doesn't outgrow its blood supply. So the tumor is sending out messages to the blood vessels grow to the tumor. So Avastin interrupts that. So what happens is the cancer tries to grow bigger, but it needs more nutrients. It can't get any more nutrients because you've cut off the blood supply, and then the cancer dies. The other thing that we have in terms of targeted therapies are the PARP inhibitors. And the PARP inhibitors, we were just using them more in the 20s. And since, late teens to 20s, since that time, they're used most often in ovarian/fallopian tube cancers. Now, what does PARP stand for? PARP is a poly ADP ribose polymerase, and it's a protein that helps repair damaged DNA. And it helps repair damaged DNA in healthy cells and cancer cells. So if you have a difficulty, if your cancer cell has a BRCA gene, then the BRCA gene is a gene that a mutated BRCA gene is a gene that can't produce the appropriate enzymes to help repair genetic mishaps that happen all the time in rapidly dividing cells. And so PARP inhibitors won't affect a normal cell because they actually have the genes or the enzymes necessary to repair them, where BRCA genes and homologous repair deficiency cancer cells can't do that, and then they die. More recently, in gynecologic cancers, immunotherapy has become important. Now, the two big immunotherapies in gynecologic cancers are pembrolizumab, which is Keytruda, which is because it's always on the TV. They advertise a lot. The other one is dostarlimab, which is Gemprolol. And these two drugs are very important, especially for endometrial cancer. In immunotherapy, it uses the body's own immune cells in order to fight the cancer. So what happens is the tumor attracts T cells, which are part of your immune systems that go to destroy foreign objects. But there are certain tumors, not all tumors, but certain tumors that have, we call them ligands, but they have little things on the surface that hides the tumor cells. And so what happens is, if I could show you a picture. So this is the tumor, and this is a T cell, and this is normal where the T cell sees the tumor and it's seen as foreign, so it would attack it. Well, some tumors have what's called PDL1 tumor or receptors and PDL2 receptors, and they can be different. Actually, they're ligands, and the T cell actually goes and binds to these substances on the tumor cell. And by that binding, then what happens is that the T cell no longer sees the tumor as foreign. And so it won't attack it and it won't try to destroy it. What Keytruda does and dostarlimab is they bind to these receptors on the T cell, and that prevents these receptors from binding to these ligands on the tumor cell. And so the T cell understands that it's foreign, and it basically will destroy the tumor cell. So in the ovarian, fallopian tube, and primary peritoneal cancers, any early cases are followed by surgery and chemotherapy. In the advanced cases, we do neoadjuvant chemotherapy. We may use Avastin. Then we do interval cytoreduction, followed by some 2 or 3 more cycles of carboplatin plus or minus Avastin. What has been really has gone into standard of care now is if your tumor is HRD positive or you have a BRCA1 or BRCA2 gene, then people recommend, or it is recommended, that you go on a maintenance therapy with a PARP inhibitor. It's a pill that you take every day. There are side effects, but you could be on that pill for up to 3 years. Sometimes we recommend the PARP inhibitor with Avastin. And again, it depends upon your particular kind of tumor. We know that maintenance prolongs the progression-free survival. We still don't know for sure if it prolongs overall survival, but we think that it does. So if you look, these are the NCCN guidelines that are fairly recent. They're 2024. And again, if you look, there's a lot of different ways you can give chemotherapy. But if you look, everything is platinum taxol, plus or minus Avastin, which is bevacizumab. And there's, if you can't have the Taxol, there's Doxil and a few other drugs. But for the most part, the primary treatment for these cancers, and notice they lump them all together, is platinum, taxane, Avastin initially, and then afterwards we do the PARP inhibitors or the Avastin as maintenance. Now, this is going to be one of the bigger things that has been fairly recent, is in treating recurrent ovarian cancer. Now, I'm not sure if you all know, but we tend to categorize patients as having platinum sensitive disease and platinum resistant disease. And the platinum sensitive disease is characterized as having no recurrence for at least 6 months following the last chemotherapy treatment. I think that's somewhat arbitrary, but that's how it's characterized. So if you have if you stop your chemotherapy and have no recurrence for 6 months, then you're platinum sensitive. And so I just want to go back, and that's important because if you're platinum sensitive, you still could have the platinum metaxates. You may want to have targeted therapy, which is the bevacizumab and the PARP inhibitors, but also you could have specific treatment for specific tumors. And this new drug, mirvetuximab, is really important for the platinum resistant group. And trametinib, which is again another targeted therapy, is very important if your cancer has been characterized as a low-grade serous tumor. The other things that we don't think about as much in gynecologic cancers, but in breast cancer, they do all the time, is hormonal therapy, like aromatase inhibitors, which include Arimidex as well as letrozole, Megase, which is a hormone, and tamoxifen. We also can do immunotherapy for either the MSI tumors or the deficient the deficient repair genes. So the two big drugs we talked about already is dostarlimab and pembrolizumab. So again, it's a big slide. I only want to point out a few things. Again, it's fairly recent. And if you have platinum sensitive disease, there are a lot of drugs that you can use at that time. You can retreat with carboplatin and Taxol, or give carboplatin and Doxil. You could give bevacizumab or Avastin. You can also do targeted therapy at that point, which are the PARP inhibitors. We wouldn't know to do that unless you had the germline testing or the tumor testing. You could do hormonal therapy. And then there's targeted therapy for specific kinds of cancer. And the one that's important here is the mirvetuximab, and also the trametinib for the low-grade serous tumors. If you have a tumor that's deficient in mixed match repair genes or an MSI tumor, again, you would not know that unless your tumor was tested, then you could be treated with immunotherapy. So I want to talk a little bit about this drug, Elahere. Here it is, mirvetuximab. It's easier known as Elahere. Now, this is an antibody conjugate treatment. And what it is the tumor has to be tested again. So you have to make sure that your cancer cells or your tumor gets tested for what's called this a folate receptor alpha, which is on the outside of the cell. So what happens is, this is an antibody conjugate, so that it's designed to fit into that receptor. And then the drug itself, the cancer killing drug, is taken into the cell, and then the cell is killed. And then if one cell's killed, you can actually, it actually impacts other nearby cells. So the newest drug that we use now is mirvetuximab, or Elahere. And you have to make sure you have a folate receptor 1 expression. And this expression is largely restricted to malignant cancer cells. It's not on normal cells. And it occurs in about 35% of patients who have epithelial ovarian cancer. And they stain it, and you have to have greater than 75% tumor cells staining. And if that is the case, and you are deemed to have the platinum-resistant ovarian cancer, that means you finished your treatment and within 6 months it came back, then this is recommended as the preferred regimen now for patients. Before we would do, well, we'll treat them with gemcitabine or topotecan or some of the non-platinum drugs. But this is now recommended by the NCCN for the first treatment following the first recurrence for a platinum-resistant cells. And in this population, the response rate is almost 52%, which is pretty good for something that's been treated and then has come back. So the only thing I want to mention in this gamish is that this is recurrent therapy, recurrent therapies. And if the cancer comes back and is platinum resistant, and this is something that's happened just in the past year, the recommended treatment is starting mirvetuximab. Now, it's a very different drug. The immunotherapist that we have in our practice actually gives the drug, but there can be eye complications, and you have to have an ophthalmologist, and you have to be followed fairly carefully. Having said that, a 52% response rate in somebody who's platinum resistance is will make a very big impact in the treatment of this disease. For all patients who have ovarian cancer, fallopian tube, or primary peritoneal, you have to realize it's not a sprint, but a marathon. And that with all of these drugs that are available, you could live a long time by using different drugs at different areas. The longest I had in my practice was I had somebody who lived with cancer, but over 20 years. So even if you recur, that doesn't mean that there are no options left. I want to talk now about endometrial cancer because there's some big things in endometrial cancer as well. Endometrial cancer is the lining, it rises in the lining of the uterus. Traditionally, the treatment has been a hysterectomy with lymphadenectomy. Now we do sentinel node biopsies. It can also be treated with radiation, either up front without surgery if you're too ill for surgery, or afterwards where you might need what's called high-dose brachytherapy, which is inserted into the vagina. What we're really talking about today are chemotherapy, targeted therapy, and immunotherapy for endometrial cancer. So first thing you have to realize is that all endometrial cancers are not the same. Although this classification is becoming a little passé, I like to think of them as type 1 cancers, where it's the grade 1 and grade 2 cancers, where the lining here looks very similar to the normal lining of a uterus, but it's too much. There's too much solid areas. Then there's type 2 cancer, where you can have a papillary serous cancer, which is similar to the papillary serous cancer in ovarian cancer, or what's called a clear cell cancers. These do not look like any kind of normal endometrium. It's thought that these type 2 cancers are more aggressive. And if you look at how the rates of aggressive uterine cancer is rising, and it has been rising in the past, and it keeps going up. This is even beyond 2015. The endometrial cancer is becoming much more common. When I started 35 years ago, there were 33,000 cases a year. Now there's 65,000. The number of cases in the United States has doubled during my career, and the number of deaths has more than doubled. And in fact, this is going to be the first year where we think that endometrial cancer will become the most lethal gynecologic cancer, because the number of deaths from endometrial cancer will probably surpass that of ovarian cancer. The other thing that you can see is that the Black population has a much higher rate of these aggressive subtypes. We don't know why. So traditionally, as I said, endometrial cancer was treated with surgery and radiation. Now all advanced cancers, stage 3s or 4, receive chemotherapy, and they could either have chemotherapy before surgery or after surgery. And the big new thing for endometrial cancer is that the chemotherapy should include Taxol and carboplatin, but women should also give or receive an immunotherapy in the form of either pembrolizumab or dostarlimab. There was a big New England Journal study that looked at dostarlimab. We've traditionally, because we were involved in a study of pembrolizumab, we've often given that. There are two different immunotherapies that essentially do the same thing. All of the type 2 chemotherapy people, all the type 2 cancers, those clear cell, papillary serous, they all receive chemotherapy, even if it's an early cancer. And again, they would either get pembrolizumab or dostarlimab in addition to that. Something that's familiar to breast cancer survivors is we talk about HER2 receptors and using of Herceptin. We now test certain endometrial cancers for HER2 receptors. And again, we might add Herceptin to the treatment regimen as well. Keytruda was added as a treatment in 2019. And if you don't have those PD-L1 receptors, then we often would add Lenvima, which is another targeted therapy. I like to think it as a sort of an oral Avastin. And that's standard treatment now as well. So again, we talked about this. The preferred treatments for advanced cancers are carbo, Taxol, and pembro, or dostarlimab. If they're HER2 positive, we would add Herceptin. It's important for the patients to realize now that these newer targeted therapies are all incorporated now first line. If it's advanced, it's really important because it can make a huge difference in treatment and survival. Just because we're talking about survival, I mentioned that there was a large report in the New England Journal of Medicine that looked at dostarlimab. Again, it's a PDL receptor blocker, and it had like nearly 500 patients in it. But what was important is, and this is something that's really important, is that the progression-free survival was much better if you added immunotherapy. So much so, if you look, if you happen to be deficient in MMR, or if your tumor type showed that you had MSI high, which is something your tumor would have, look, these are the months difference between the dostarlimab group and the placebo group. Even if you looked at the general population, those patients did better. If you looked at even the people who didn't have that deficiency, they still did better than those that didn't. And again, this is the survival again. And again, the dostarlimab people really did much better. So immunotherapy has really been utilized much more successfully now and should be used first line in all of the endometrial cancers if you're a candidate for chemotherapy. The other thing if you look at chemotherapy for recurrent disease, it's sort of the same. There are some tests that you do to see if immunotherapy would be better. But then in certain cases, there's also, as I said, lenvatinib and pembrolizumab are better if you don't have those MMR deficient tumors. And again, there are some other newer immunotherapies such as nivolumab. And then we also use Herceptin for HER2 positive patients. Lastly, I want to talk about cervical cancer. I know we're going through this quickly, but traditionally cervical cancer was only treated with either radical hysterectomy and bilateral pelvic lymphadenectomy in early stages, and everyone else beyond stage 1 and 2 were treated with chemotherapy. And that would be a radiation therapy, radiation therapy. And that would be in the form of either external beam radiation and intracavitary radiation, where we would put the radiation source up inside the uterus to treat the cancer and surrounding tissues. It was probably in the mid-90s when there was a flurry of excitement where we learned that if you added chemotherapy with the radiation as a radiation sensitizer, those patients did much better. The other things that can happen is you could, in advanced cases, we would use chemotherapy, and then there's targeted therapy. The one that we use most in cervical cancer is Avastin, but also immunotherapy. So in general, we use these agents most often in patients who have widely metastatic disease. Now, if you have a cervix cancer and it's advanced or recurrent, you should have your tumor tested for the PD-L1 testing. Again, that's for Keytruda, or pembrolizumab is the generic name. When we also should test them for MSI, microsatellite instability, or a deficiency in MMR, mixed match repair genes. And that should be done on all the tumors. 10 years ago, we were never testing tumors, or rarely testing tumors for all these specific age or entities. But now all cervical cancer should be tested for this. Multimodality therapy has been most successful. And we currently combine chemotherapy and targeted therapy, which is Avastin, and immune therapy. The preferred, if you have an advanced cervical cancer, then the preferred regimen is paclitaxel, which is Taxol and cisplatin. We often add Avastin, and if you have PD-L1 positive tumors, then we would add pembrolizumab as well, or Keytruda. This has made a huge difference in responses. Some of these patients who have very advanced cancers, you can actually see the tumor melt away. So if you have a cervical cancer, and it's for all the cell types, the first line treatment is cisplatin and Taxol. If you have PD-L1 positive tumors, then you would give Pembro plus cisplatin plus Taxol, plus or minus Avastin. And it's not uncommon now where we have an advanced cancer where they get 4 drugs, where they get chemotherapy and targeted therapy and immune therapy. One thing I do want to mention is cervical cancer prevention has been very successful. Not very many people realize that the successful HPV vaccination was first developed here in Rochester. We recommend that you do routine vaccination at age 11 or 12, but you can start as early as 9. Vaccination is recommended for everyone through ages 26. And it's usually given in 2 to 3 doses. It's important for me to say, though, that HPV vaccination is not just for women or young girls, that it's been found to be very effective in decreasing oropharyngeal cancers in men. Also, it could decrease the risk of penile cancers, but that's a rare entity to begin with. But whether you have a young boy or a young girl, we should recommend that you have those people vaccinated. It's not been mandated, and I know that there's a lot of controversy about it, but from a gynecologic oncologist point of view, is we believe that cervical cancer can be prevented. Now, the new thing for cervical cancer prevention is it used to be that if you didn't get it by 26, you didn't get the vaccination by 26, you've probably been exposed by HPV. So it's not worth it getting it. But that's not what we think anymore. I mean, based on the discussion with your clinician, now they're extending the age for HPV vaccination to up to 45 years. It may provide less benefit because a lot of people have already been exposed to HPV. The last thing I wanted to say about the vaccination is that it can sometimes be used in precancerous conditions of the cervix to prevent recurrence of those. In terms of our outlook, research is being done. Things have changed a lot. Standards of care are changing. There's lots of clinical trials that are available. And for all of these cancers, I think we have hope. So I am done. Did I make it in time?
It was just perfect, Dr. Angel. Thank you so much for all of this information. And thank you, Rachel, for putting in the chat our registration page that's coming up for the rest of these. If you missed any of today's presentation or you would like to review it, we'll have the recording on our website shortly. And thank you for the questions that came in. We've got those noted, and we will ask Dr. Angel those at the end of the month too. Wonderful. Oh, yes. The Gynecologic Cancers 5K walk and run is this Saturday at MCC. I know I'll be there. I'm looking forward to it, hoping the weather is just gorgeous like this. That's wonderful. Thank you so much for your expertise and for joining us today, taking time out of your day, and to everybody who's here as well. Thanks a lot. Enjoy your day.
Thank you. Bye-bye now.
Bye.